The following podcast is part of a certified educational activity titled Teaming Up to Reduce the Burden of Cancer-Associated VTE, Applying the Latest Guidelines and Evidence in Gastrointestinal and Hematologic Malignancies and Other Cancer Settings. Access the entire activity and complete the post-test at peerview.com/XDU860. Downloadable slides and practice aids are also available.
Welcome to Teaming Up to Reduce the Burden of Cancer-Associated VTE, Applying the Latest Guidelines and Evidence in Gastrointestinal and Hematologic Malignancies and Other Cancer Settings. I am Alok Khurana from the Taussig Cancer Institute in Cleveland, Ohio, and I'm pleased to welcome my colleague, Jean M. Connors, MD, from Boston. Our agenda today is to unlock the potential of DOACs in cancer-associated VTE. There's been a whole new wave of evidence-based information that's come out in the past year to 2 years, both in the clinical trial setting as well as in the real-world setting. And that's led to a paradigm shift in the treatment of cancer-associated VTE, as well as opened up options for the primary prevention of cancer-associated VTE. So today we'll apply this latest evidence, and the goal will be to help reduce the morbidity and mortality of cancer-associated VTE in GI cancers and hematologic malignancies, other solid tumors. And at the end of this webcast, we'll do a summary and do audience Q&A as well. So we look forward to an exciting hour. Let me start off focusing on the subject, the potential of DOACs in cancer-associated VTE. I'll speak first, and then I'll transition to Dr. Connors at separate sections. So we'll sort of do a back and forth this evening. Let's start by understanding why cancer-associated VTE is important. The scope of the problem is shown here. The incidence, as those of you who take care of patients with cancer, is very high, especially compared to other patients who don't have cancer but have similar comorbidities. So even if you're considering a population of patients that's sick and often needs to go to the physician, there's still a lot of greater risk of venous thromboembolism and also arterial thromboembolism, although we don't have time to discuss that today, in cancer patients versus non-cancer patients. And this applies to not just DVT or PE, but many other types of thrombotic events as well. The incidence varies quite dramatically by the type of cancer, and that's shown in the graph on the right. You can see the control population, which is non-cancer patients, all the way on the right. But some cancers that have higher rates include lung cancers and pancreatic cancers, primary brain tumors. There's a whole list of types of cancers that are strongly associated with the risk of VTE. And when cancer patients get a venous thromboembolism event, it's not just the venous thromboembolism event that they have to deal with, but there's also consequences that flow from that. It is one of the leading causes of death in cancer patients. When you combine the category of venous and arterial events, the rates are quite high. And as we discussed and will continue to discuss this evening, they're even higher in patients with pancreatic and gastric cancer, and hence today's focus on GI malignancies as well. As an oncologist, one of the things we are always worry about is what impact do certain events have on our patient population in terms of survival. And unfortunately, study after study has shown that cancer patients who are equal in all other aspects, so the same stage, same performance status, same type of cancer, same type of systemic therapy regimen that they're receiving, if they get a blood clot versus if they don't get a blood clot, the outcomes are worse. So there's greater risk of short-term mortality and a greater risk of long-term mortality in cancer patients who develop a DVT or PE as compared to similar cancer patients who don't develop a DVT or PE. Why this is not clearly understood. There's certainly a lot of mechanisms that drive the association of cancer with the hypercoagulable state. Despite knowing about the association of cancer with thrombosis for over a century, we still don't fully understand what is the benefit to cancer cells in having a hypercoagulable state, and what are the mechanisms within cancer cells that drive such a hypercoagulable state. This graph describes some of the postulated mechanisms. And these are very varied. So they can be something as completely separate from the coagulation system, but rather caused by activated platelets, for instance. And many of the systemic therapy regimens that we use can activate platelets. Many of the interventions we conduct in cancer patients, such as putting a central venous catheter in, or doing major surgery, can affect endothelial cells, platelets, and directly through damage. Many treatments and cancer itself can lead to a pro-inflammatory phenotype, and that can lead to NETs, which are these neutrophil extracellular traps, which in turn can lead to a hypercoagulable state. There's a generation of inflammatory cytokines. There's increasing data that IL-6 and IL-8 may be involved in this process. And then many cancers express tissue factor, which is the prime initiator of the coagulation cascade under physiologic conditions. But they express tissue factors on the cell surface of cancer cells, even in organs where tissue factor is not normally known to be expressed. Pancreatic cancer, for instance, is a great example where normal pancreas never expresses tissue factor. There's no reason to, because you're not going to bleed in the pancreas. But as soon as a normal pancreas transforms into malignant pancreas, you start to see expression of tissue factor across the majority of specimens. And when there's fully invasive pancreatic adenocarcinoma, upwards of 80 to 90% of patients express tissue factor on cell surface. And this tissue factor is shed into the circulation and can be measured in the circulating blood. So many different mechanisms seem to be driving this process, inflammation, tissue factor expression, activation of platelets, activation of leukocytes, neutrophil extracellular traps, and so on. And it may not be all explained by one specific mechanism. Not shown on this slide, but important to consider is, why do cancer patients need to have a hypercoagulable state, and why do so many malignant conditions need a hypercoagulable state? Why is it important for cancer biology? And there's some really elegant experiments that have shown that if you downgrade the hypercoagulable state, you actually affect cancer biology and cancer outcomes. So even though it's an older complication, we've known about it for over a century, there's still some really fascinating science that waiting to be discovered so that we can understand it better than we do now. In terms of clinical application, the risk factors underlying the incidence of DVT or PE in the cancer population are important to understand. The best known risk factors are cancer-related. I mentioned already the type of cancer, so GI malignancies, for instance, primary brain tumors are strongly associated with the risk. Breast cancer patients, for instance, may have a much lower risk than those categories. Histology is important. Even in a subgroup of the population, such as lung cancer, adenocarcinomas seem to be at higher risk for developing DVT or PE as compared to squamous cell cancers of the lung. The grade, a poorly differentiated cancer is more likely to cause clots than a well-differentiated cancer. And timing, so the first few months after diagnosis of malignancy is also when patients are most at risk for a DVT or PE. There are certainly treatment-related factors. I mentioned some of them already. Major interventions that are done to cancer patients, major surgery, procedures such as putting a catheter in, hospitalization, systemic therapy, chemotherapy, immunotherapy, central venous catheter placement, even supportive care measures such as erythropoiesis stimulating agents or blood transfusions can all increase the risk. There's certainly patient-related risk factors. Older patients are more likely to get clots. In the US, African Americans are more likely to get clots as compared to whites and Asian Americans. Patients who have other comorbidities, kidney dysfunction, pulmonary issues are more likely to get clots than not. And then there's a bunch of biomarkers. They can be as simple as a platelet count or leukocyte count, or they can be more complex biomarkers such as a D-dimer or a p-selectin or thrombin generation potential. So lots of science around understanding the risk factors associated with DVT or PE in the cancer population. Because there are so many risk factors, it follows that this disease is multifactorial. And so my research group has held for years that the prediction of risk in cancer patients can't be based on a single factor. So you can't say, oh, it's just pancreatic cancer patients or just primary brain tumor patients. It's a mixture of many of these different risk factors. About a decade ago, we developed and validated a risk score that's shown here that includes the type of cancer and scores assigned for specific types of cancers. So stomach or pancreas, you'd get 2 points. Lung cancer, you'd get 1 point. Colorectal cancer, which falls under other in this list, you'd get 0. Breast cancer, you'd get 0. So that it preserves sort of this association of the type of cancer with the risk of DVT or PE, but it also acknowledges other risk factors, including a high platelet count, for which you get 1 point, a low hemoglobin, a high leukocyte count, a high BMI, all of which you would get 1 point. High risk in our original classification was determined to be a score of 3 or higher. So you could get 3 by just having pancreatic cancer and one of the other factors, such as a low hemoglobin. Or you could get to 3 points by having one of the lower risk cancers, such as breast cancer, but having, let's say, a high BMI and a high platelet count and a high leukocyte count. So there's different ways to get to a score of 3 or higher. This risk score has now been validated in multiple studies. The last we looked at this, it was upwards of 40,000 patients that had been that there were published series on evaluating the efficacy of the score. Our most recent validation study was from a couple years ago in the United States of about 6,000 patients. And as you can see in this study, as well as in many other studies, the risk is not neatly categorized as 3 or higher, but in fact grows from a score of 0 to 1 to 2 to 3 to 4, and so on. So that brings up the question of, is the high-risk cutoff of 3 or higher adequate, or should it be lowered to a risk score cutoff of 2 or higher? The best data for this comes from the Vienna group that was the first to validate our risk score prospectively. And as you can see in the graph on the left, what they found was that if you follow these patients for about 6 months, for patients with a score of 2 or higher, the 6-month cumulative incidence was around 10%. In a meta-analysis of the score in 35,000 patients, as shown on the right, we also arrived at a roughly 9% rate of symptomatic DVT or PE at 6 months. And this becomes important because 2 recent prophylaxis studies that we'll discuss later this webcast used a cutoff of 2 or higher for entry into the study. And so that's an important question to try and understand as we discuss the application of understanding risk in this population. Another point to make is that the risk of VTE also varies over the course of illness. I mentioned that the highest risk period is at the initial period when patients are first diagnosed, but the risk can go down at times of remission or after patients have been on chemotherapy for several months. It can spike really steeply in the setting of an acute event, such as hospitalization or major surgery. It can almost disappear in the setting of remission, and it can obviously recur if the malignancy recurs. And so risk assessment is not something that's done at a single time point, so not just when you're first diagnosed. It needs to be done at various time points along the course of this illness. As the setting changes, the recommendations for prophylaxis will also change. There's certainly been a lot of efforts. As I mentioned, our risk score came out back in 2008. There's been a lot of efforts to try and improve upon this risk score. They're listed here. Some of these efforts involve inclusion of biomarkers such as a D-dimer or P-selectin. Right now, the guidelines currently recommend the original risk score, but we are hopeful that as these newer risk scores evolve and are validated, we may have better ways to identify high-risk patients in this population. Now, risk score is only helpful when it can be utilized for the benefit of patients with cancer. And one of the primary benefits of risk assessment can be utilizing our understanding of risk and our ability to predict risk, and then offering primary prevention to those patients that we consider at high risk. To discuss primary prevention of cancer-associated VTE in 2020 in the light of very recent large publications, I'll now hand off to my colleague, Dr. Connors, to discuss these very exciting new data. Dr. Connors?
Thanks, Dr. Khurana. As Dr. Khurana said, we're going to lead in from his ability to predict risk of VTE in patients into what can we do to prevent a primary VTE in patients who have cancer. So, as Dr. Khurana alluded to, just in the last year, just over a year ago at the American Society of Hematology meeting in 2019, we had a presentation or publication of two risk modifying studies in patients with cancer. The first was actually led by Dr. Khurana, which in the upper left-hand panel, you can see the title Rivaroxaban for Thromboprophylaxis in High-Risk Ambulatory Patients with Cancer. That was the Cassini trial, which I will be discussing. And then Dr. Carrier had led the study called Apixaban to Prevent Venous Thromboembolism in Patients with Cancer, with a very nice editorial accompanying both these publications in the New England Journal a few months later by Dr. Giancarlo Agnelli from Italy. So I'm going to discuss both AVERT, which was the Apixaban trial, and Cassini in some detail. And as Dr. Khurana mentioned, these studies used risk stratification to identify patients at high risk. The reason these studies were so noteworthy and actually exciting for those of us who work in the malignancy field, and particularly malignancy and associated VTE, is that they did something unique compared to studies that were done approximately a decade ago. Studies using low molecular weight heparin for primary prophylaxis in patients with cancer had been performed a number of years ago. However, if you took unselected patients and took all patients with solid tumors getting chemotherapy in the ambulatory setting, while you could reduce the risk of primary or first VTE with low molecular weight heparin, the actual number of patients this reduced the risk in was on the low side. So roughly 5 to 6% of patients in these trials had VTE if they were treated with placebo, and you could reduce this risk by almost 50%, but that's a very small number of patients to begin with. So the strengths of both the AVERT and Cassini trial is that they use the Khurana risk assessment score to try to risk stratify patients and identify those who had higher risk of VTE who might better benefit from prophylaxis. The AVERT trial took newly diagnosed patients with malignancy after remission and initiating a new course of chemotherapy for at least 3 months, and selected those that had a Khurana score of 2 or greater, and then randomized to either Apixaban or placebo for 6 months. In the Cassini trial, ambulatory outpatients with solid tumors or lymphomas were also randomized, and they were selected again using the Khurana risk assessment score with a score of 2 or greater and an expected survival of more than 6 months. All of these patients in both trials had to be starting new chemotherapy. And the randomization scheme in Cassini randomized to Rivaroxaban or to placebo. What's very important to note about the Cassini trial is that just prior to randomization, patients underwent screening ultrasound, and at that time point, approximately 4.5% of patients were found to have VTE, particularly deep vein thrombosis of the lower extremity, and those patients were not enrolled in the trial, somewhat changing the risk of the cohort that went on to be randomized. Here are the key efficacy endpoints in both AVERT and Cassini. You can see them side by side. With AVERT, if we looked at Apixaban, 4.2% of patients receiving Apixaban developed a VTE, compared to 10.2% in the placebo patients. This was found to be statistically significantly different between those two arms. In the Cassini trial, the composite efficacy endpoint up to day 180 of VTE was found to be 6% in the Rivaroxaban arm, and 8.8% in the placebo arm. And it should be noted that this is the modified intention to treat analysis, where the difference between these two groups was found not to be significant. However, if we look at the on-treatment group and looked at the composite efficacy, those treated with Rivaroxaban experienced VTE 2.6% of the time, compared to those in placebo at 6.4%. So in AVERT and Cassini, the key efficacy endpoints were VTE in the AVERT trial. And when we look at those patients treated with Apixaban, 4.2% developed VTE, compared to 10.2% of patients who were assigned to receive placebo. The hazard ratio was 0.41 with a p-value that found this to be statistically significantly different. When we looked at the Cassini trial and the composite efficacy endpoint at 180 days in the modified intention to treat analysis, 6% of those patients on rivaroxaban compared to 8.8% of patients assigned to placebo experienced primary VTE. And you must keep in mind that 4.5% of patients were screened out before enrollment because they had already developed a VTE. This was not found to be statistically significant. However, if you look at the on-treatment analysis with the composite efficacy of patients who actually took the prescribed treatment for the duration of time, 2.6% of patients taking rivaroxaban compared to 6.4% taking placebo experienced VTE. The key safety endpoints were both major bleeding and clinically relevant non-major bleeding for both trials. In the AVERT study, the major bleeding using the ISTH criteria, which were used in both, were 3.5% for patients in the apixaban arm compared to 1.8% in the placebo arm. And clinically relevant non-major bleeding slightly higher in the apixaban arm versus the placebo arm. For Cassini, again, similarly low and even lower rates of major bleeding with rivaroxaban in the rivaroxaban arm at 2% versus 1% in placebo. And clinically relevant non-major bleeding also not that different between the two arms. So in clinical practice guidelines for cancer-associated VTE have not all caught up with the information found in these trials. When we look at the Asco guidelines for patients with cancer and primary thromboprophylaxis, Asco recommends that only those patients with a Khorana score of 2 or greater get prophylaxis with apixaban, rivaroxaban, or low molecular weight heparin, and patients with myeloma on thalidomide or lenalidomide-based regimens with aspirin or low molecular weight heparin. Primary thromboprophylaxis is recommended by NCCN for those patients who have intermediate or high risk for VTE, again based on the Khorana score of 2 or greater, with apixaban or rivaroxaban. Low risk patients with myeloma are advised to take aspirin. Those with high risk and myeloma on an IMiD-based therapy regimen can be treated with apixaban, low molecular weight heparin, or warfarin per NCCN guidelines. ITAC for primary thromboprophylaxis similarly recommends that those with locally advanced or metastatic pancreatic cancer treated with systemic anti-cancer therapy be treated with low molecular weight heparin. Other patients with cancer at intermediate or high risk of VTE with the Khorana score of 2 or greater can be treated with either apixaban or rivaroxaban. The ISTH also in its guidance statement suggests that primary thromboprophylaxis be used only in cancer patients with a Khorana score 2 or greater and specifies either apixaban or rivaroxaban. So you can see from this slide that there is some variation in the recommendations from these societies with how to approach patients who might be at increased risk for VTE and the use of primary VTE prophylaxis in this setting. Now, when we look at clinical practice guidelines for cancer-associated VTE for hospitalized patients who are admitted for medical reasons and have no risk for bleeding, all societies listed here, including ASCO, NCCN, and ITAC, recommend VTE prophylaxis in the inpatient setting. And for patients with malignancy who are admitted for major surgery and have no contraindications to anticoagulation, the recommendations are similarly slightly varied amongst societies, with ASCO suggesting 7 to 10 days or up to 4 weeks after discharge in high-risk patients, NCCN stating continue for 4 weeks post-discharge for high risk. And similarly, ITAC 7 to 10 days or up to 4 weeks based on the patient's individual risk for VTE. So we've now going to field questions from the audience. They've been submitted to us electronically, and Dr. Khurana and I will discuss answers to these questions that have been submitted. Our first question from the audience, Dr. Khurana asks, in cancer patients with a history of DVT, does the length of thromboprophylaxis increase? And what?
Yeah, it's a great question because I think the questioner is indicating that a prior history of DVT may be a greater risk factor for recurrent DVT while patients are on systemic therapy for cancer. I think my takeaway is that if they are already on a therapeutic dose of anticoagulation, they should remain on it. If the history of DVT is remote, then they should at least start on prophylaxis appropriately, depending on what their score is for DVT or PE. And at 6 months, we can reevaluate whether there's been any risk of, whether the risk of bleeding has changed. This is a data-free zone since all of the thromboprophylaxis trials only study duration of anticoagulation for prophylaxis up to 6 months. So I think anything beyond that has to be a very carefully considered discussion with the patient before we would make that decision.
Okay, and question number 2. Are there similar guidelines for patients that are elderly? And what are expert-based thromboprophylaxis recommendations for those with advanced age?
That's also a terrific question. It's important to note that the geriatric age group is a huge proportion of cancer patients receiving systemic treatment and may be underrepresented in clinical trials. Having said that, both Avert and Cassini did not have an upper age limit for enrolling, as far as I know, for enrolling patients into the clinical trials. And there were several hundred elderly patients included in those trials. So I think we can take the data presented at face value from Avert and Cassini and apply it to the geriatric patient population, obviously taking into account individual risk factors for bleeding, comorbidities, renal issues, and so on. Before making a decision. As far as I'm aware, there are not specific guidelines for the geriatric population regarding prophylaxis.
No, I agree. I'm not aware of guidelines specifically for the elderly. I think we all know that it is an older cohort of patients that tend to have cancer, so the average age may be older in patients with cancer than in other situations. We're going to switch back to Dr. Khurana presenting on treatment of acute VTE in cancer patients in 2020. Dr. Khurana?
Yep, thank you. So just as you heard this excellent summary of the change in primary prevention and new evidence in primary prevention, there's also been a paradigm shift in the way we treat thrombosis in the cancer population. So this is secondary prevention or treatment of VTE in cancer patients. And that also has undergone a shift over the past few years as new data around the class of direct oral anticoagulants has come out. Let's review what the latest evidence on the use of direct oral anticoagulants is in the treatment of acute VTE in the cancer population. This one slide actually displays the 4 major trials around this, or the 4 large published trials around this. The first 2 to come out are shown on the left, Hokusai VTE, which was a very large trial of cancer patients with acute symptomatic VTE. Over 1,000 patients were randomized to receiving low molecular weight heparin and then transitioning quickly to edoxaban. And that's because edoxaban does not have a label of starting as initial treatment, so you overlap with low molecular heparin and go on to edoxaban. Versus what for the last 15 years or so had been the standard, which is dalteparin, 200 units for the first month, and then dropping to 150 units per day for the next 5 months. So 6 months of low molecular weight heparin monotherapy being the control arm. Since that remains the only FDA-approved low molecular weight heparin, they chose to use dalteparin, although I know many of us use enoxaparin or generic enoxaparin in this setting. The 3 other trials also had the same control arm, but they differed with the study arm. So SELECT-D used rivaroxaban, Adam VTE and Caravaggio used apixaban. Caravaggio was the larger of the two apixaban trials. Again, over 1,100 patients were enrolled in Caravaggio, and these data just very recently came out in the New England and was presented at the American Heart Association in the middle of the COVID pandemic. Let's look at what these data show us. This slide, remember, when you're thinking about replacing low molecular weight heparin monotherapy as your standard, the two things you're looking for are, if you use a new drug, is the risk of recurrent VTE going to be the same or a little bit better? So recurrent VTE rates. And the second, of course, is, does it lead to increased risk of bleeding or not? To demonstrate non-inferiority, and these different trials sort of approach it differently, but to demonstrate non-inferiority, you have to show similar rates of both recurrent VTE and major bleeding, if not an improvement. And if you look at these rates, you can see in Hokusai VTE, the rates of recurrent VTE were lower for edoxaban, about close to 8% compared to 11% for low molecular weight heparin. Because of the way the sample size calculation was made, which was made on a combined efficacy and bleeding platform, the study was not powered to show improvement, but it was powered for non-inferiority. So the p-value is not significant for superiority, but for the combined endpoint, it was significant for non-inferiority. SELECT also had the same theme, less rates of recurrent VTE, 4% compared to 11% with low molecular weight heparin. So the control arms were very similar rates, and both showed a reduction of recurrent VTE with the DOAC. Adam VTE was a much smaller study, and so very few events actually occurred in this study for both bleeding and recurrent VTE, but there were lower recurrent VTE rates with apixaban, 0.7 versus 6%, and Caravaggio, which was again powered towards non-inferiority, showed a non-inferior recurrent VTE rate, but a numerically lower recurrent VTE rate consistent with the other three trials. So in terms of our first objective, are the recurrent VTE rates the same or at least maybe even a little bit better? I think the summation of this data suggests that they're definitely the same, and perhaps even thematically they appear to be numerically lower in some studies and even significantly lower in other studies. So we can be assured that a direct oral anticoagulant used instead of low molecular weight heparin monotherapy will not adversely impact the rate of recurrent VTE and may potentially benefit patients in terms of reducing the risk of recurrent VTE. What about the flip side of the coin, which is major bleeding? And here you see also the flip side of the results. And so a drug that's potentially more of a blood thinner may cause more bleeding, and you see increased numerical rates, and at least in Hokusai, significantly increased major bleeding rates, so 6.9% versus 4%. SELECT-D, 6% versus 4%, not significant, but roughly the same numbers. You did not see that in the two apixaban trials, 0 versus 1.4% for Adam VTE, and then 3.8 versus 4% for Caravaggio. Although these trials occurred a few years after Hokusai and SELECT-D had reported or were ongoing while those two earlier trials were being reported. A third aspect is, of course, you want to make sure that there's no difference in mortality, or that your drug is not causing cancer patients an increased risk of mortality. And as you can see across all these trials, the p-values were not significantly worse for mortality across any of those clinical trials. The Caravaggio data are very, very recent, but the Asco and ITEC guidelines took into account the older clinical trials, and NCCN, which just came out, at least addressed some of the Caravaggio results. Overall, all three guidelines have changed compared to their last editions from a couple years ago, and now include direct oral agents as an option for the first-line treatment of acute VTE. So Asco offers either low molecular weight heparin transitioning quickly to edoxaban as an option, or rivaroxaban as an option. Again, apixaban data had not come out at the time of the Asco update. NCCN allows any of these, apixaban, edoxaban, or rivaroxaban, although it expresses a preference for non-gastric or non-gastroesophageal cancers, and we'll discuss why a little bit later in this discussion. Low molecular weight heparin preferred for gastric or gastroesophageal cancers, again driven by this sort of risk of major bleeding that we'll show some slides later on. And then DOACs, if these are not acceptable, which would be a very tiny minority of the patients. The The ITAC guidelines also allow for initial treatment with low molecular weight heparin or with DOAC or with heparins, followed by either low molecular weight heparin or DOACs. And again, that represents a change compared to the prior edition of these guidelines, where low molecular weight heparin monotherapy for 6 months was recommended as the only treatment option for these patients. So that's also a massive shift in the way we consider the treatment of acute VTE in this population. So again, we'll move on to an audience Q&A. These questions were submitted electronically, so let's review a couple questions so that we can go on to some cases and then finish up on time. So question 1 is, what factors, again this is about duration, so what factors should guide the decision to stop or continue anticoagulation therapy after an initial treatment period of 3 to 6 months in cancer patients at increased risk of VTE? Dr. Connors, what clinical factors do you consider about stopping versus continuing anticoagulant therapy in treatment of VTE in cancer?
Well, Dr. Khurana, somewhat similar to as we discussed with patients for whom we're considering primary prophylaxis, depends on what status the patient is at the time we're evaluating. For patients who might have had a post-op VTE from cancer surgery and have completed any adjuvant chemotherapy, or for those who've completed all of their chemotherapy and have no evidence of disease, the decision to stop anticoagulation after 3 to 6 months is pretty straightforward. For those patients who have persistent cancer, however, or for those who are getting active treatments and persistent cancer or any permutation of those variables, then our tendency is to continue anticoagulation to prevent them from getting a recurrent event. And at that point, again, we have minimal data as to what the best dose or what the best agent is. And so to summarize, I would continue anticoagulation in a patient who has advanced cancer and is continuing to get treatment. Dr. Khurana?
Yeah, I agree. I mean, we would, especially for patients with metastatic disease that are going to be on treatment for a while, we would continue beyond that time point. A second question, Dr. Connors, is about managing a massive iliac DVT or a PE. And do you have preference for catheter-directed thrombolysis over DOACs or low molecular weight heparins? Again, this probably applies to a very tiny minority of patients. I can't remember the last time I saw something like this, but do you have a preference for thrombolysis?
No, and again, I think these days we pick up patients very early. You know, they have frequent touches with our care team, and our all of the members of our care team are aware of the heightened risk of VTE in cancer patients. I think I can remember one patient that I directed to catheter-directed thrombolysis, and that was 3 years ago.
Yep, a tiny handful of cases over the years. So let's move on, since we're running short on time, to a couple of the other topics we had promised to address at the start of this webcast. Number one is the GI malignancy issue, and there's sort of a concern for both increased risk of recurrent VTE as well as the risk of major bleeding. Quickly, let's go over this case of John, who's a 68-year-old patient with pancreatic cancer, presents with DVT or PE. This person does have a high BMI, is significantly anemic, and the ultrasound does confirm DVT. Dr. Connors, you talked about prophylaxis, and this patient now has a DVT, but could have benefited from prophylaxis because their score between having pancreatic cancer, high BMI, and low hemoglobin is 4, which is very, very high. Treatment for pancreatic cancer, especially in the metastatic setting, focuses primarily on either a doublet regimen of gem Abraxane or a triplet regimen of FOLFIRINOX, both of which are fairly aggressive systemic therapy regimens. So if this patient is on a doublet regimen of gem and Abraxane, now has a new acute bilateral DVT, what choice would you make in terms of treatment? Would you choose a DOAC? Would you choose a low molecular weight heparin? Would you choose a warfarin? What do you think, Dr. Connors?
Well, I think, my understanding of pancreatic cancer, and you're the expert, Dr. Khurana, is that although the risk for VTE is high, The risk for bleeding is not what we see in patients with gastric or esophageal malignancies, or patients that might have an intact primary in a mucosal surface. So for this patient, I would feel comfortable using one of the direct oral anticoagulants for which we have data to treat the new DVT.
Yeah, I agree. I think the concern about bleeding risk with GI malignancies, and we'll look at a couple slides shortly, is driven primarily by the gastric or esophageal cancer population. So having a luminal gastric cancer or esophageal cancer certainly is associated with a high risk. And that patient, so a patient with metastatic gastric cancer in which the primary is intact, I would probably prefer low molecular heparin. For this patient, and it doesn't say that the tumor is invading into the duodenum or anything like that, then I think a DOAC would be a good alternative as well. Obviously, we want to go over both the risk of bleeding and recurrent VTE with the patient and understand their preferences in terms of injection versus oral agent and whatever other insurance issues may play a role as well. But I think a DOAC would be very, very reasonable in this setting. A good way to sort of think about this is this algorithm from our Canadian colleagues, and I personally sort of follow this, which is any new cancer patient with a new DVT or PE, the two questions you need to understand are there any drug-drug interactions with DOACs, and is there a high risk of bleeding? If the answer to both of these is no, so no interactions and not a high risk of bleeding, start with the DOAC. If there is an interaction, then start with the low molecular weight heparin, and then obviously reassess at 6 months and then make a decision as to whether to continue or not. The concern about the risk of GI bleeding is driven by this subgroup analysis of the Hokusai VTE cancer study, where you can see if you focus on just the GI cancer patients that were enrolled in Hokusai, the risk of major bleeding is really, really high with the direct oral agent compared to a low molecular weight heparin. That's in contrast to the graph on the right, which is non-GI cancer patients enrolled in Hokusai, and you can see there's actually no excess bleeding at all if you exclude the GI cancer patients. Unfortunately, this doesn't give us a further breakdown of the GI cancer population, so we don't know how many of those were pancreatic versus esophageal or gastric or rectal with a rectal mass, and I think that's where we need to exercise judgment in terms of understanding risk in this population. A second issue to consider is, does the risk of VTE persist? That's a question that was sort of attempted to be answered by the SELECT-D trial, where there was a second randomization at 6 months. And as you can see here, recurrence VTE rates were lower with the continued rivaroxaban as compared to placebo, but the sample sizes were very, very small, and so the hazard ratio overlaps, the confidence intervals overlap. And of course, if you continue rivaroxaban as they did in this trial, then you do get a greater risk of bleeding, including major bleed and clinically relevant non-major bleed. So we have to address both aspects of this when we discuss duration of treatment of VTE in this population. In contrast to some of these studies, the newer studies with the ATOM VTE shown on this slide shows no difference in major bleeding, but it was a much smaller sample size. More reassurance from the Caravaggio trial. Dr. Connors, you were on the steering committee of this trial. Not in terms of recurrent VTE, certainly apixaban seemed to be a little bit better than dalteparin. Again, this is a theme across all the DOAC trials. But in terms of safety outcome, major bleeding seemed to sort of overlap. Would you agree with that assessment?
Absolutely. We found that the rates of major bleeding really did not differ between those treated with apixaban or those treated with dalteparin. And so, again, based on your patient's individual characteristics, I might choose one DOAC or another depending on the individual patient.
Yep. And I think this Caravaggio being such a large study, I think provides reassurance that you can safely select patients for treatment with DOAC without being overly concerned about doing harm. So for this patient, you could choose a DOAC or low molecular weight heparin. I think both Dr. Connors and I have expressed a preference for DOAC in this setting, but it's certainly you're not wrong to use a low molecular weight heparin. Reassess at 6 months and then make a decision about duration of treatment. Another example sort of taken from the real world is this next case of breast cancer in a patient with a comorbidity of renal disease. Dr. Connors, did you want to discuss this case?
So very briefly, this is a woman who was diagnosed with ER-positive HER2-negative breast cancer in 2015 and underwent lumpectomy with a negative lymph node dissection. She was eligible for hormonal therapy, but did not receive it for a variety of reasons, and ultimately presented a few years later with evidence of bony metastases and diagnosed with metastatic breast cancer. She is evaluated for types of treatments, and then there's been a huge explosion, if you will, in the cancer treatments available for patients with breast cancer, starting with tamoxifen is the only treatment for patients with metastatic breast cancer in 1980, and we can see a variety of hormonal agents came on board in the 1990s and early 2000. But when we move to today's available medications for patients with metastatic breast cancer, we can see a wide variety of types of treatments that have come out just in the last few years. And we can point to a variety of different medications, including abemaciclib, that might increase the risk of VTE. And so these CDK4/6 inhibitors for metastatic breast cancer are actually considered first line treatment in these patients. So many cyclin-dependent kinases are listed for these patients, depending on their stage of treatment and what their past history of treatments for their metastatic breast cancer has been. And again, if you look at NCCN guidelines, you can see that cyclin-dependent kinase inhibitor is recommended as first line now in some of these patients. And so for our patient, she is started on abemaciclib in February 2019. But then is found to develop pulmonary embolus. And if we had looked back, we might have realized that perhaps she was at a bit increased risk for developing VTE, given her BMI of 38 and her hemoglobin of 9. But nonetheless, she's diagnosed with pulmonary embolus. What should be considered in her is that she has borderline creatinine clearance and has had known chronic kidney disease for a number of years, with a creatinine clearance right now of 31 ml per minute. And so in this patient, I would certainly consider using a DOAC. She does not have a GI tract malignancy and is not at increased risk for bleeding from a DOAC. However, we need to look at the drugs that she might be taking, as Dr. Khurana alluded to that great diagram and flowchart from our Canadian friends. One of the big issues to address is whether there are any drug-drug interactions that might occur due to cancer medications, which are not seen in the non-cancer population. And then what can we do about this creatinine clearance, and is that of any concern? When we look at the PK/PD profile of DOACs in renal insufficiency, one of the things that I tend to focus on is the percent renal elimination, because the more dependent the patient is on renal clearance of the drug, the more likely they are to accumulate higher levels if they have any fluctuation in their renal status. And we can see here that apixaban has about 25% renal elimination compared to rivaroxaban, which is 33%, but dabigatran has a significantly high renal elimination pathway. We also need to look at drug-drug interactions, particularly with the P-glycoprotein transporter and the CYP3A4 enzyme system in the liver. So in this patient, none of the medications that she's on that interfere with DOAC metabolism, and given her chronic kidney disease with a creatinine clearance that's just borderline acceptable for use of DOACs, I would choose apixaban because it has the least amount of renal clearance. Things to assess in your patient include whether there might be any complications from chemotherapy in your patient who has a newly diagnosed VTE, how to manage anticoagulation peri-procedure, whether your patient might need an invasive diagnostic procedure or surgical excision if they might have a new lesion, all affect sometimes the choices of anticoagulants that we use. And as Dr. Khurana and I have both discussed throughout today's presentation, we really tend to individualize the treatment based on not only the clinical status and stage of the cancer or the risk of recurrent VTE and bleeding, but we also include the patient and the patient's preference in this calculus for determining the best choice of anticoagulant in any given patient. Okay, our next case involves a 58-year-old woman with newly diagnosed multiple myeloma. She presents with symptoms of worsening fatigue and dyspnea on exertion, and in addition to her symptoms is noted to have a BMI of 38 and has a past history of DVT. We can also see that she has significant anemia with a hemoglobin of 7.8 and a total IgG well over 6,000. The skeletal survey shows multiple lytic lesions, and a diagnosis of multiple myeloma is made. She is treated with RVD chemotherapy, Revlimid, Velcade, and dexamethasone for 4 cycles. Just briefly, with regard to therapy for multiple myeloma, thalidomide derivative type agent is preferred in patients such as lenalidomide, bortezomib, and dexamethasone, the generic names for these drugs, although cyclophosphamide, bortezomib, and dexamethasone are also an option in some patients, or some combination of a thalidomide type agent. In our patient, we want to initiate RVD. She gets started on RVD, but before she gets started on her first day of treatment, the nurse practitioner involved in her care asks if she should be treated with a low-dose DOAC for primary VTE prophylaxis. Her Khurana risk assessment score is performed. She's found to be at high risk based on that, as well as the fact that she is getting a thalidomide derivative IMiD-based agent, and she is initiated on apixaban in addition to her RVD treatment. There may be some concern about drug-drug interactions, particularly with apixaban and CYP3A4 and PGP transporter and efficacy, as dexamethasone has some impact on these metabolic pathways. However, in this treatment regimen, the dexamethasone is administered once a week, and as this was being given for prophylaxis, it's felt that the risk from drug-drug interaction is not that high. When we look at cancer-associated thrombosis in clinical practice, again, we're looking at our wonderful flow chart for assessment of patients from our Canadian colleagues as to how to select a choice of agent and whether we select an injectable agent or a DOAC and whether that's right for our patient. So just a word about drug-drug interactions which can occur in patients when they're taking anti-cancer therapies that might inhibit or induce P-glycoprotein or CYP3A4. All of DOACs are substrates of the P-glycoprotein transporter, and apixaban and rivaroxaban are also substrates of the cytochrome P450 CYP3A4, whereas edoxaban and dabigatran are only metabolized by the PGP system. If you're using a low molecular weight heparin, there are no drug-drug interactions. However, some DOACs do have drug-drug interactions, and we'll review those in a second. Many centers advocate that patients with thrombosis should have a pharmacist-led drug interaction evaluation at the start of chemotherapy or whenever therapies are modified and class of cancer treatments are switched. Some of the tyrosine kinase inhibitors and immune modulating drugs will affect the DOAC metabolism. And we can see from this chart here that sometimes they are not predictable, and that you need to either involve a pharmacist or look at some available websites that look for drug-drug interactions and verify whether or not the drug you're choosing might inhibit or induce CYP3A4 or PGP. So in our patient who has multiple myeloma being treated with a first-line regimen, including an IMiD and additional risk factors, we recommend pharmacologic prophylaxis. And quite honestly, you could use apixaban, rivaroxaban, or low molecular weight heparin. This particular patient in particular might benefit from shared decision making as all patients, but given the past history of VTE and the BMI, we would discuss using primary prophylaxis in her. Clinically, again, multiple myeloma is a standalone risk category in a lot of society guidelines. If you're going to use an IMiD for treatment of the myeloma, it's associated with a known increased risk of VTE. Individualization of the patient's approach and treatment for primary prophylaxis is based on not only their risk-benefit profile, renal function, and drug-drug interactions, but also patient preferences. And one last point is that patients really need to be educated about the importance of adhering to anticoagulant treatments. And you'd be surprised at how many patients may not recognize that twice a day or once a day are on a schedule and not morning one day and evening the next day. So next set of audience questions that were electronically submitted to us. How would you manage VTE in patients receiving induction chemotherapy for leukemia or undergoing bone marrow transplant? Do the experts prefer low molecular weight heparin, rivaroxaban, or apixaban? And is there any data to guide this? Dr. Khurana?
It's a great question. It is challenging in this population because of the severe thrombocytopenia that can accompany treatments for all of these different illnesses. I think many of these patients are hospitalized, and then hospital formularies typically tend to carry the low molecular weight heparin and not so much some of the more commonly used outpatient drugs. There are no data at all in hematologic malignancies, and I think that's a major concern in this population as well. So I think there's sort of a slight preference for low molecular weight heparin in this population, but again, this is not based on any data, and it's based more on the logistics of being able to supply this. What about you, Dr. Connors? In your institution, are there preferences?
We certainly tend to avoid oral agents such as the DOACs because their half-life is a bit longer than low molecular weight heparin. As you noted, particularly if they're undergoing stem cell transplant, they are hospitalized and profoundly thrombocytopenic. So we often in those patients even use IV unfractionated heparin on a heparin drip because it has the shortest half-life. Sometimes the issue of transfusing platelets arises, and I think we look to the severity of the thrombosis to guide how aggressive we should be with the anticoagulation. If somebody has a significant PE with high clot burden and is symptomatic, we try to push for full intensity anticoagulation and may need to transfuse platelets in that setting to safely anticoagulate them. And that leads to question 2, because the data on the cutoff value for platelet count to stop anticoagulation really doesn't exist with regard to hard, fast data. However, we tend to use a threshold based on expert consensus of somewhere between 30 to 50,000. And so, Dr. Khurana, would you prefer rivaroxaban or apixaban or other agents in cancer patients with a low platelet count defined as less than 30,000? What would you reach for in this setting?
Yeah, I think that's a great setting, again, with very little data. I actually participated in an ISTH guideline and also large systematic review that looked at specifically this question, and we're talking about a handful of patients and a couple case series that is the extent of the published data regarding this. I'm a solid tumor oncologist, so thankfully, such low platelet counts are uncommon in my population. Generally speaking, at up to a platelet count of 50,000, I tend to keep whatever drug they're on at whatever dose they're on. Between 30 and 50,000, I drop to prophylactic dose of whatever drug they're on. Less than 30,000, for prophylaxis, I tend to stop and not use an anticoagulant at all. If it's therapeutic, we could have a discussion about sort of continuing on prophylactic doses for therapeutic reasons. If it's expected to be a transient period, then I think it's reasonable to sort of stop for a couple of days and wait for the counts to bounce back. I think if it's expected to be for a longer period of time, using platelet transfusions or using a filter, there are other things that are on the table that could be considered.
No, I think that's an excellent point with regard to timing too, because not only timing of the platelet count and whether or not you expect it to recover if they have a hematologic malignancy, but also how far out they are from the diagnosis of the VTE. So somebody who had a pulmonary embolus 6 to 8 weeks ago, I would be more concerned about being able to continue anticoagulation in those patients. And again, as Dr. Khurana, I would certainly try to use full intensity anticoagulation down to a platelet count of 50,000 and sometimes maybe even 40,000 before dropping the dose. And in those patients, we do, if their renal function is okay and they're not bleeding, we might use a DOAC, but otherwise we then switch to an intermediate or prophylactic dose of low molecular weight heparin. But part of it depends on what their risk of recurrence is at that time and whether or not we expect their platelet count to recover. The last question, thromboprophylaxis is mandatory in patients with myeloproliferative diseases such as ET, essential thrombocytosis, or polycythemia vera, I think is what the question is driving at. But what is your opinion regarding thromboprophylaxis in lymphoproliferative malignant disease? And Dr. Khurana, your opinion would be valued?
So if this is referring to lymphoma patients, those were included in both AVERT and Cassini, and there was benefit for the overall population that included lymphoma patients. So I think there's certainly evidence to support using prophylaxis, again, based on selection for high risk, so not for all lymphoma patients, but based on selection for high risk.
And I totally agree. Those with a higher risk score will benefit. So it's not just the disease, but it's the individual patient characteristics that help drive the decision about using thromboprophylaxis. We're now going to switch gears, and Dr. Khurana is going to present some selected highlights from ASCO this year, our new virtual meeting in the setting of COVID-19. Dr. Khurana?
Yep, thank you, Dr. Connors. So to finish up our webcast, and thank you all for your patience, I thought it would be interesting to look at a couple highlights from ASCO 2020. And so here's a couple abstracts that I wanted to briefly discuss. One is from Dr. Martin and colleagues looking at rates of primary prophylaxis. So Dr. Connors gave you a great overview of last year where we had these new data come out. And then this year when a lot of the guidelines updated to include the new data and recommend thromboprophylaxis, but what's actually happening in clinical practice. Dr. Martin and colleagues found that only at their academic center, only 1 in 10 patients with gastric and pancreatic cancer received a prescription for prophylactic anticoagulation. And unfortunately, because most of these patients were not prophylaxed, there was high rates of incident VTE at 6-month follow-up, reaffirming the unmet need for primary prophylaxis in clinical practice. This is not completely surprising because the data for outpatient prophylaxis is fairly recent, and then the guidelines updates are even more recent. But I think this serves as a benchmark to what's actually happening in clinical practice, and hopefully we can improve the rates of compliance with the appropriate prophylaxis in high-risk patients as we learn more about this data and then implement this data in a more efficient manner. Speaking of how to implement these data in a more efficient manner, there's a great paper from Holmes and colleagues out of Vermont looking at ways to sort of use the ambulatory cancer clinic program and how to incorporate a model that allows prophylaxis to be offered and to be implemented. So what these colleagues did was, this was just published in the Journal of Oncology Practice, an Asco publication just in the past few weeks. What they did was they took an electronic health record risk assessment tool using this type of methodology. They had a communication plan to explain why prophylaxis is important. And then they incorporated both education and evaluation by pharmacy, as well as having patients meet with a thrombosis specialist to discuss risks versus benefit of prophylaxis, and then to provide prophylaxis to this population. What they found was that a referral to a hematologic service for patients at high risk for VTE led to a greater success in identifying high-risk patients, in educating them about the warning signs and symptoms of DVT or PE, and then utilizing prophylaxis. And this, I think, is one way to overcome the current implementation gaps between what we know from clinical evidence and from guidelines into clinical practice, so these data can influence and benefit patients. Finally, this abstract from the Asco virtual program is a single-center study of the safety and efficacy of DOACs versus low molecular weight heparins by McShane and colleagues. And they looked at rates of VTE recurrence, major bleeding, and mortality in this population. Again, this is a representation of real world. We know that patients who are enrolled on clinical trials are generally not as sick or not as unhealthy or don't have such a poor performance status as the patients that we see in clinical practice. And thankfully, they seem to find that VTE recurrence rates, major bleeding rates, and mortality rates were either similar or no different than compared between DOACs and low molecular weight heparins. Remember, these were not randomized patients. They were assigned one category versus another based on different reasons. But these data support what we see in the clinical trials and support the real-world use of direct oral agents in this setting. So thank you, Dr. Connors, for an excellent overview of some of the prophylaxis treatment options and walking us through some very complicated cases. I think for our audience today, some of the take-homes are that cancer-associated VTE remains an important cause of death in cancer patients. DOACs are now clearly an option for the treatment of cancer-associated VTE. One option is to consider screening for pre-existing VTE prior to starting anti-cancer therapy at the Cleveland Clinic, where I practice. That's something we've taken into the electronic health record and have published about this. Secondly, it's important to recommend VTE prophylaxis in high-risk outpatients with DOAC or low molecular weight heparin based on the latest update of the Asco and NCCN guidelines. For treatment, anticoagulation should be continued for at least 6 months. For managing acute VTE, certainly for treatment, bleeding complications remain a concern with DOACs, and so we have to be mindful about individualizing treatment and making sure that we select patients safely. But the results from Caravaggio and some of the later clinical trials in this setting are reassuring, suggesting that this is an important way to treat cancer-associated VTE with direct oral agents in a safe and efficacious manner. You've been great at submitting questions and listening to this webcast, so I thank you for your patience. Dr. Connors, did you have any closing remarks before we finish up here?
No, thank you, Dr. Khurana. I think we had a great discussion and we had excellent questions from the audience, many of which describe real-world practice situations that we encounter for which we need more data. So we look to people like yourself, Dr. Khurana, to provide us with that data in the future.
And one of the important messages I think we should communicate is, this is a win-win for cancer patients. The risk of recurrent VTE and major bleeding can be very safely managed. with the advent of new options for the treatment of cancer-associated VTE, and as I think it's incumbent on us to, to identify patients at risk for both bleeding and for thrombosis, and then apply some of these strategies that we've learned from clinical trials. So thank you, Dr. Connors, very much for this discussion, and to the audience for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XDU860. Supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance.
This activity has been jointly provided by Medical Learning Institute, Incorporated, and PVI, Peerview Institute for Medical Education.